A very warm welcome to Global Healthcast COVID Special, a co-production between Global Health Press and the Coalition for Life Course Immunization, CLCI. This podcast was made possible through an unrestricted grant from Novavax. Our 6 COVID specials will cover epidemiology and surveillance, long COVID, which is today, COVID in children, vaccines and vaccination. I am Joe Schmitt, and with me throughout the 6 COVID podcasts will be Professor Catherine Weil-Olivier. Hello, Catherine.
Hello, everybody.
Our topic today is long COVID, and it is our great pleasure and honor that for this topic we have with us an outstanding expert, Professor Danny Altmann. Welcome, Professor Altmann.
Hello, nice to see you.
Professor Altmann is Professor of Immunology at the Imperial College in London, where he heads a laboratory at the Hammersmith Hospital campus. His research interests focus on the immunology of infectious diseases, including severe bacterial infections, SARS-CoV-2, Zika, and chikungunya virus, and he has a long record in autoimmunity research. Professor Altmann has served for over 20 years as editor across several medical journals, including Oxford Open Immunology, Immunology, and Vaccine. He acted in a range of roles during the pandemic, advising policymakers like the House of Commons and the House of Lords Science Committees, the UK Department of Health, the European Union, and WHO. Professor Altmann is a trustee at the Long COVID Support Foundation, and his SARS-CoV-2 research is published in excellent journals, including The Lancet, Nature, and Science. He's currently heading a UK government-funded research program to look at mechanisms of pathogenesis and development of new diagnostic tests in a large cohort of individuals with long COVID. Without any further delay, I'm very honored and pleased to have you all here for this session today. And I am the one to start with the first question, which is, Professor Altmann, how common really is long COVID?
Yeah, it's an important question. So we debate a lot about how to count it, yes, which is non-trivial because many people never get to see a doctor. There's no recognized test for it. But having been round and round on this in many countries, in many studies, in many data sets, I think we've all come to agree that of all the people on planet Earth who've ever been infected with COVID-19, about 10% of them have persistent symptoms that last for more than 3 months. So if you try and guesstimate how many people have ever been infected with COVID-19, my assumption is always that we have now a planet with about 400 million people with long COVID.
So this is a relevant public health topic. 400 million people, 10% with COVID get it. So this is really a major public health problem.
It is. So, you know, I wouldn't be sitting here and you wouldn't be sitting here if we didn't think it was a major public health problem. But it's one of those public health problems that's very difficult territory, isn't it, for politicians and policymakers? Because if you have a pandemic emergency and you have to try and keep your country going and your economy going and avoid imminent deaths, you have certain courses of action. If you're told that there's a proportion of your population who might be in poor health or using health services or not going to work for the coming years, it could be your problem, it could be the next government's problem, it could be somebody else's problem. It's a very strange kind of health emergency to try and get people to address, I think.
Yeah. Catherine.
Yes, I have a query about vaccines. Some studies show that maybe it is protecting against long COVID. Others say maybe it is decreasing the duration or the intensity of symptoms. So we are speaking now on next booster for the next fall with these new monovalent targeted vaccines on the variant mostly circulating these weeks. So what is your opinion about that?
Yes.
What was initially the role of the vaccine? What will we do for the next season?
Okay, so I think in terms of vaccines and long, let's start with vaccines and long COVID. I think it's really important to answer the question clearly because people get very polarized and angry about this question, and it's quite hard to disentangle the different components in it. So the first part to your answer obviously is a simple answer, which is that the best way to not get long COVID is to not get COVID. And the best way to not get COVID is to be effectively vaccinated with protective immunity. And then we can have a whole discussion and perhaps on a separate question about what and how frequent would the vaccine program be to have effective protective immunity at this stage in the pandemic with our current variants. But let's put that to one side for the moment. So I'm saying get vaccinated. Not getting COVID is a good way to not get long COVID. And then within that question, people again get very perplexed about why did they say that having the vaccine would decrease or prevent long COVID? There's still so much of it around and so many new cases. And again, you've got to be very hard-nosed about the data on this. The answer is that in the Omicron period, the number of cases in all affected countries has rocketed because it's very transmissible. And proportionately, the amount of severe infection and the amount of long COVID has gone down. But a small proportion of a very large number of cases is still a large number of people. So we have a large number of people with long COVID in the current vaccinated period. So in the UK, for example, in the post late 2021, early 22 period, we've gained something like 700,000 cases of long COVID in the vaccinated plus Omicron period. So does that mean that vaccines don't work? No, of course it doesn't mean that. It means they're not perfect and can't keep this completely at bay. And then layered on top of that, you've got a more nuanced argument that's been of concern to people with long COVID, which is if I have long COVID, will vaccination make me better? And that's one of our complex questions of long COVID treatment, isn't it? So again, looking at many, many data sets, it looks to me like the answer to that is of all people with long COVID who've been vaccinated or boosted, maybe a third got better, a third stayed the same, and a third claimed they got worse. And we can't even say on that, what does that data mean? The third who got better, would they have got better anyway? Because some people do get better from long COVID, we don't know. On the other hand, you could say, well, if we're saying that some people have long COVID because they have a persistent reservoir of virus that they didn't manage to get rid of, maybe a vaccine could help them. So, we just don't know enough yet.
Yeah. And finally, would the best advice could be if you have an additional risk factor, an underlying disease, please vaccinate yourself because you have to protect.
Yeah, that's a massive, massive point, isn't it? Because again, we're at such a strange point in our evolution of our relationship with this virus now, aren't we? In terms of how we behave, how our governments behave, and we almost feel like it's safe and it's okay to go back to normal, because for most people, most of the time, if you get another infection or you get another Omicron breakthrough infection, maybe it'll be like a bad cold, or you'll be off work for 3 or 4 days and life will go on. And yet in all the countries where we assess these things, excess mortality is still, is still high. There's still many, many excess deaths, many excess hospitalizations, and that's skewed towards people with comorbidities, isn't it? People with malignancies, people with type 2 diabetes, people with asthma, people who are elderly. So obviously, whatever else we need to do, we need to pay extra attention to making sure that the most vulnerable people are the most vaccinated.
Yeah.
Professor Altmann, looking a little bit into myths and reality on the diagnosis of long COVID, and very often the disease is just self-reported, or you feel fatigued, you don't feel well, you think you have long COVID. Well, what do you think about the argument that this is all about depression during a long lockdown? Is this just a consequence of not being able to have normal social activities? Or what is your view here to this argument?
Yeah, no, it's a comment that's often made to me, and worse than that, I just feel like in many countries we came into the pandemic already in a very polarized and divided mindset about so many kind of, political and socioeconomic disputes, and we just sort of overlaid our opinions on COVID on top of that. So every time I speak anywhere, and even speaking to quite influential, important people, I hear that COVID is all in the long COVID is all in the mind, or long COVID people are people who don't want to work, who simply want to claim benefits instead of working. And you can imagine it does make me very despondent, because I see this as part of the spectrum of human chronic disabling disease like any other. And I could bore you for many hours talking about all the kind of clinical correlates and data correlates of that, in terms of serum biomarkers or imaging on MRI or imaging on PET, and so many beautiful studies that have documented this, that show you so conclusively that it's really not all in the mind. And apart from being insulting to the sufferers, it's kind of ironic, because in our center, where lots of people come to take part in our long COVID study, I see what a lot of people with long COVID are like face to face. And the majority of the people I meet are previously active, high-flying people who did busy jobs, did a lot of sport, had busy lives, have had their lives very unexpectedly taken away from them by this infection, and want their lives back. They don't want to be lying at home on a sofa, feeling bad. They just want their life back.
Yeah. Catherine, this sounds interesting, right? It is a major diagnosis. It changes your life, right?
Yeah, I think so.
Yeah.
When we have some people interviewed, clearly it is downsizing their life.
Yeah.
And so you will speak a bit about that later on. For my part, I'm a pediatrician, basically. So I wonder if certain segments of the population are more at risk of long COVID or not. Have you seen long COVID in children? It seems it's much lower as a percentage of risk. Is it more in young adults or older adults or risk groups? What is your notion about that?
Yeah. So again, lots to say about that. So I think children have confused us throughout COVID, haven't they? Because we started out by saying that children weren't at any risk at all, and they could go to school normally and get infected normally. And across much of the world, we watched our schools go, 90, 95, 100% seroprevalent, seropositive, as people became infected in the schools. And I don't know what the answer was or is to that. All I know is that although long COVID is clearly less common in children, and we have fewer children than adults across the world with long COVID, they really are a sizable group. They're a significant group.
Mm-hmm.
And how devastating is it to take children long-term out of school with a chronic disabling condition that means they can't sit their exams, they can't do their lessons, they can't play with their friends, they can't carry on with their sports. What a horrible, horrible thing to do to them. So yes, it may be somewhat less than the adults. And in terms of symptom sort of spectrum and profile, perhaps slightly different to adult long COVID. We and others are collaborating to work on that at the moment, but it's there. We talked about comorbidities, and how people with comorbidities, including things like diabetes and asthma, may be at greater risk. It's quite complicated to work out, who's the person who's really at risk of long COVID and who isn't, because there are many myths out there. The first thing to say is that from the earliest studies, if you cast your mind back to 3 years ago, when we first started looking at cases of COVID and severe COVID, your typical hospitalized person was often male, a bit older, a bit more overweight, and they tended to do worse and be in hospital for longer. So they're heavily represented in the first wave of long COVID cases. They're older, more likely to be male, more likely to be hospitalized, maybe even in intensive care. as we've moved forward through the many waves of the pandemic, that's no longer a typical long COVID person at all. Now they're, perhaps 2 or 3 to 1, a young middle-aged woman, often normal body mass index, not necessarily hospitalized or given oxygen or intensive care. One of the baffling and horrific things about long COVID is that you're at risk from it, whether you were hospitalized and very severely infected, or were in bed at home, or were mildly infected at home, or even thought you were asymptomatic. You're all at risk of long COVID. It's one of the many bizarre and insidious things that the virus can do in your body. It doesn't matter how severe it was.
Okay. So basically, that pattern has changed, and it is now affecting basically everybody in the society. And it's interesting to hear about children. Do we know any?
That's the point. Could we say that it is unpredictable?
It is unpredictable. There's one in terms of predictability. I think there's one important qualifier I left out. When we talk about long COVID skeptics, one of the things that I see coming up a lot in social media is, the people who have long COVID are the people who can afford to have long COVID because they're at home working on their laptops and baking their sourdough bread recipes. And it's the kind of worried, well, middle classes who have long COVID. And again, if you look at the data, that couldn't be further from the truth. COVID and long COVID have been diseases disproportionately of socioeconomic deprivation, because the people who can't afford or have jobs where they can't afford to work from home, or the people who, when they're ill and know they're ill, don't have work contracts where they're allowed to take time off work, they've been more hit by COVID, and they're also roughly have double the risk of long COVID compared to the people in the highest socioeconomic brackets. So it's important for us to remember this isn't a condition just of chatting people in chat rooms and social media groups in the middle classes. It's a disease of everybody across the world who had COVID-19.
Very good.
Let's look a little bit into underlying mechanisms. Can you give us some highlights on theories, hypotheses, or real findings? What causes long COVID?
Yes, so that's you'd think that question was becoming easier and easier to answer, but if anything, it's becoming harder and harder to answer. So when we started out, we had on the table in front of us all of the obvious hypotheses. Yes, that any of us could come up with, that it's quite a toxic virus to cells. It gets into many cells and organs in the body that have this receptor ACE2 on them. So you can see damage in some people in their lungs and in their hearts and in their kidneys and in their blood vessels. So could it be direct damage by the virus? And then you have people saying, we've seen differences and problems in clotting and coagulation and blood clots that can cause a lot of the consequences, like higher risk of strokes and mini strokes, and problems of gas exchange and exhaustion in the lungs. So maybe we should be looking at that. And then you have immunologists like myself saying, well, some of this looks a little bit like the way that viruses like Epstein-Barr virus cause glandular fever and really, lay you out low and leave you absolutely wrecked for, maybe, often 6 months or a year or 2 years, with enormous correlates of immune white blood cell changes. Could it be a bit like that? And then you have lots of people measuring autoimmunity, the way that your immune system gets turned on to attack itself and attack different parts of your body, that we know that some viruses do. Can we find evidence for that? And we certainly can. So you can see what I'm saying here. I'm saying I have a long list of hypotheses that we all laid out 2.5, 3 years ago, and we've all gone away and done research on lots of those things. And there are many thousands of publications out there in the medical literature showing examples of all of these things. And because we can only work so fast, what we've been very bad at so far is knocking heads together and pulling all these stories together and saying, sure, we can measure all those things. So at the end of all this, what's really the answer where we can make a difference? Sorry, not a very satisfying answer.
So basically, we are still in the process of finding, of verifying hypotheses. Let me put it this way.
Yeah, many answers, but no big answer that could make the big difference to the sufferers.
Okay.
And finally, no biological marker, easily
And again,
accessible.
lots of candidates, no particular biological marker. One that perhaps I should come back to and mention is, because it's considered a kind of low-hanging fruit for therapeutic trials and treatment, is if, as some people with long COVID believe, maybe they have a persistent infection with the virus and they never managed to clear the virus when they first got it. If you could find those people and do clinical therapeutic trials on those by giving antivirals or by giving monoclonal antibodies, you'd guess you could make them better. So that's one thing that we debate a lot, and we try and find those people and try and find, research methods to spot, are there people with persistent virus perhaps in their gut? How do we spot them and how do we treat them?
So with all those uncertainties, we are circling the fact that maybe it could be an umbrella for different disease entities. You just evoked that.
Yeah, no, it's, I think we accept that the trigger for all these different things was, that virus getting into your body. But it's hard for me to understand why, the 70-year-old man who 3 years ago was in intensive care with very severe COVID, who now complains that he has brain fog and word finding difficulties, is necessarily the same disease process exactly as the 16-year-old teenager who, since their Omicron, has a lot of gastrointestinal problems and can't stop with their diarrhea. So it doesn't have to be all the same mechanism.
Okay, so I don't think we can go further in all those mechanisms, and it's triggering our interest, but especially the perspective of treatment. So it leads to the next point, that maybe people feel frustrated by the slow progress to drug trials. And what just you said, explain why it's so slow.
I think it's a complex question with a complex answer, isn't it? So the movement to understand long COVID and recognize it and treat it has been uniquely led and beautifully led around the world by the sufferers themselves. I've never seen anything quite like it. It's to some extent a product of the social media internet age. People point out parallels with activists during HIV/AIDS in the mid-1980s, but it's not quite the same as that. This really is sufferers trying to take a lead on the research agenda in a very sort of beautiful and engaged way. And a byproduct of having a global community who are so engaged is that they're also very angry. They're very furious with us about the slow progress, with varying opinions, some of them almost seeing it as a kind of conspiracy due to lack of interest and lack of concern to delay available treatments when we could just have a go. It's difficult, isn't it? Because clinical medicine is a conservative and risk-averse business for very, very good reasons. And we don't tend to be pressurized by patients into just having a go and giving people a potentially dangerous drug just for the heck of it because they've said they don't mind. So I wrote a book about long COVID together with a sufferer called Jez Medinger, and we made a kind of double act in the writing. And the Times newspaper referred to us as the odd couple, because he was a crazy patient who was so desperate he was prepared to treat himself with anything he bought on the internet, sometimes landing himself in hospital extremely unwell. And my role in the book was to be Professor Boring and be very angry with him and try and sort of drag him back down to earth. So that was, the nature of our dialogue. But that kind of encapsulates the situation, doesn't it? That how can it be that if the scientists working flat out not very surprisingly, in 2.5, 3 years, haven't managed to just gain more mechanism and insight than we have, say, in lupus in the last 100 years. We're catching up, but we don't know enough. When I have, cold, hard-nosed debates with colleagues, we have difficulty deciding what are the best candidates to put on the list for clinical trials, which are the things that we think are really evidence-based and sensible.
Yeah. Look, this reminds me of AIDS in the 1980s, right? Everybody wanted to have treatment now, and everything was out there and nothing worked until ACT came along, and then we had combination treatment. So this is a very similar situation, but we have no clue what is the cause of the disease, really. I mean, we have some ideas, but if you don't know what it is, how can you treat it, right? It's a frustrating situation for everybody. Now, coming a little bit back to empirical findings, would you have any data how long COVID really lasts?
I think that's one of the most challenging and emotional questions, isn't it? As I said, people are so desperate to have their lives back, and also it's an area where we find it very hard to collect data. So we can just about collect national data in different countries on different measures, different proxies for who has long COVID. We're even worse at collecting data for who's come out of that data set, who's recovered from their long COVID. Not least because it's very subjective, isn't it? It's not a one day to the next thing. It's, oh, hang on a minute, I couldn't ride my bicycle, and now I'm thinking about riding my bicycle again, so maybe my life is returning. So it's not a binary thing. It's a very complex thing to measure. Yeah. So it's hard to do. And yet, when I talk about 10% of the infected people, that's hard data that's out there. So, is that 10% going down? Are we on the plateau of a curve? Or, is it moving? So the one thing to say is that in the UK, where we've had until now quite a robust data set from the Office for National Statistics, we've been stuck on a plateau of somewhere between 1.7 million and 2 million cases that hasn't really gone down, because as a small proportion of people have got better, more people have been infected by Omicron variants and had persistent symptoms. Anecdotally, sure, I hear stories all the time about people who considered themselves to be long COVID sufferers who now feel that their life has kind of gone back to normal, as in they couldn't do their job full time anymore, and now they've gone back to work, which is terrific, and we need to be better at counting those people and telling their stories. At the same time, we know many people, and this is a little bit like the story of MECFS, a myalgic encephalopathy, chronic fatigue syndrome, where we certainly have a hard core of people who simply year after year after year haven't remotely got their lives back. And there's resonance for that in SARS-1, the 2003, 2004 SARS infection, where because I was trying to look into a crystal ball of what would happen to people with long COVID, I became very passionate about trying to contact clinicians who'd worked with people with SARS and say, well, you're 20 years further down the line. What happened to your patients? What was their story? And bearing in mind that those were people who were very severely unwell, were not always expected to survive, were in intensive care. When you look at what became of them, I was very interested in the people in the University of Toronto who were treated there. And the story of those people was that all the people who were treated then had persistent symptoms, and virtually none of them ever returned to normal, and virtually none of them ever returned to their former jobs. So a very depressing way of saying it can go on for a very long time.
Bad news.
That's variable news, variable.
If I may, is there any correlation between the duration of long COVID symptoms and the severity of the disease initially?
Yes, it's a surprisingly hard question to answer.
Yeah.
So sort of, yes. Okay, so one of the studies that I really love in the UK, so the UK did some things very badly and some things very well. one of the things that was done very well at the beginning was kind of using the National Health Service to set up some very big, large-scale national studies with very good data collection and very good data curation. And one of those was called FOSP COVID, for post-hospitalized COVID, and it collected into the study everybody who was in the first wave of hospitalizations and agreed to track their progress over the subsequent years through really detailed testing and laboratory tests, biochemical tests, cognitive tests, lung function tests. And so because that skewed to people who were rather unwell and rather severe in their first wave of infection, it's got an incredibly high prevalence of long COVID, much higher than the figures I was talking about before, perhaps 30 or 40%. So that kind of suggests that they're abnormal in being more prone to long COVID, having had a more severe first wave infection.
Some people with ME/CFS complain that they are ignored because now all the research and all the resources go to long COVID. Are these two entities really different? Is there something similar? How is their relation from a nosological point of view?
Yeah, I think an important point. So I was a part of the large group of the medical research community who hadn't thought before enormously about ME/CFS, not least because we can only work on things that we can get research funding for. And I saw almost no examples of anybody managing to apply for research on ME/CFS and managing to kind of succeed and get money and do anything important. So therefore, I couldn't fight a crusade on this without any research funding. So I was one of many who was guilty of not doing anything. On the other hand, I do think it's been important and advantageous and educational to start to link together the two conditions. We now see them under a common banner of post-viral or post-infectious sequelae or post-viral syndromes, and there clearly are incredible commonalities there. And I often refer to it as a Rosetta Stone moment where one can help us to decode the other. And so I've belatedly and guiltily reread the research literature on ME/CFS, and the commonalities are amazing, right down to specific species of gut bacteria that are found disturbed in both conditions, specific biochemical markers in the serum that is disturbed in both conditions. So, all I can say to the people who are very angry with me and with us for having ignored ME/CFS is, yes, you're right, but now there's a real moment of opportunity to help both conditions and learn something.
Very good. And so we are entering back again the field of care, and it's certainly a very difficult field. What is your impression? Well, what would be the best advice to give to people with long COVID?
So I've made a bit of a hobby of trying to understand care pathways for long COVID in different parts of Europe and different parts of the world. And as you'd expect, they're very disparate and very heterogeneous. And yet the problem for the long COVID patient is the same whether you're in South America, North America, Western Europe, or Eastern Europe, or the UK. It doesn't matter. Your problem is the same. I see almost no gold standard examples where I think that the sufferers are getting a fair deal or an appropriate deal. And I think it's a very difficult discussion to have, isn't it? Because, we claim to be living in a civilized 21st century society, and we claim to have modern medicine at our fingertips. And here are we saying that we've, put on hold or destroyed or damaged the lives of, at my estimate, something like 400 million people. And I could write you the kind of shopping list of what a fair deal would look like for those people, that they could go and see their doctor, and their doctor would refer them to a specialist center, where at the specialist center there would be specialist clinicians who would take them seriously for a multi-system, multi-organ relapsing and remitting disease, and there would be rheumatologists and respiratory physicians and nephrologists and neurologists and psychiatrists and occupational therapists, and all of the experts would be under one room in a sort of one-stop shop. And the people would go there, and at the end of all of their investigations, including some imaging and some blood tests, they might be prescribed a therapeutic, a medicine, a drug that had come out of our trials that we're all trying to kind of get started on, that would make them feel somewhat better and give them some of their life back. Okay, so that's my dream, and that's what I say whenever I'm asked by policymakers what we should do. And I can't think of a country on earth that's a tenth of the way to delivering that, or even contemplating how you could pay for it.
Yeah.
And so, as we have no specific treatment, what would be the best advice to accompany those people? That is the role of doctors. When they see their patients, they have no real treatment to propose.
Yeah, sure.
What would be, what are the best surroundings for those patients?
So you know, I think we're at such a difficult point, aren't we? You know, with I often describe the long COVID clinics as a situation of panic on both sides of the desk, panic from the patients and panic from the doctors, wondering what to do next. Yeah. And when people ask me for referrals to friends who are long COVID clinicians, there are no long COVID specialists. Nobody's done it. Nobody has the answers. Nobody has developed the wonder treatment. So all I can do is send them to the most sympathetic colleagues who I think have the best understanding of general internal medicine, who can use their knowledge of general internal medicine to say, okay, so this person clearly has a problem of breathlessness. What do I normally do for people with breathlessness? Let me try my box of tricks and see what can help. So I send them to those kind of people, which is better than nothing, but not really good enough. And it comes back to our earlier discussion that it's a race, isn't it, to try and do some basic research, try and identify some candidate drugs that might help, and try and just get something on the shelf to help them.
Yeah. We understand the very frustrating situation, frustrating for the physician, frustrating for the patient. And maybe in the end of our meeting today, I come back to the very first sentence that you said, one of the first sentences: the best way to not get long COVID is to not get COVID. So my last question to you for today is, what would be the recommendations you would give for vaccines and vaccination for the upcoming winter and autumn season?
Yes, again, we're at such a hard point in our relationship, aren't we? Where, again, different countries are adopting very different policies and very different solutions. And a lot of confusion, yeah. So on the one hand, amongst professional immunologists and vaccinologists, very sophisticated mechanistic discussions about how you would achieve the most effective cross protection against the current Omicron subvariants to really try and drive better protection in the population and get down those reinfections and breakthrough infections that are still destroying us. There's still so many people off work, so many people missing from the workforce. Why aren't we taking it seriously? And sometimes I look across at different countries and I slightly despair at the solutions that policymakers are adopting, from the ones saying, well, we've got a lot of economic problems, we've got a lot of demands on our budget. We'll do a cost benefit analysis on how many people are likely to die and how many lives we could save per dollar of vaccine. And we'll do a sort of minimal calculation of how to distribute whatever doses we can buy, whatever vaccine we can buy at the best price. We don't need to worry about all those fancy professors telling us that some of them protect from Omicron and some of them don't. That's just detail. And we'll just buy whatever's going cheap. It's a bit like going to Aldi and going to see what's on the center aisle on discount this week. We'll get whatever's on discount, and we'll do something. And so clearly by my profession, you'd expect me to be a maximalist who doesn't like people getting infected with avoidable, dangerous infectious diseases, who'd rather we gave people the best possible vaccine to protect everybody. You know, why would I not say that? And I just look at the way that we're bedding in ever mutating, ever damaging new viruses into our global population, and think that when the historians write their history books in 100 years' time, they'll scratch their heads and curse us. Say, you know, what were people thinking of in those days? Why didn't they save us from this thing and do a slightly better job? What was on their minds?
Yeah. Catherine, any last comments, views, questions?
No, I think you summarized so well the uncertainties about long COVID,
Yeah.
and the fact that many units, research centers are interested in the topic and try to go further. The fact is that science is slow and we need time. And this is something maybe not very understandable for the public,
Exactly.
as everything is going so fast and we have news within a minute when it appears on the opposite side of the world. And so it makes a frustration for the public, definitely. And we may consider that the situation of long COVID is still a frustration. But the reality...
This was a very nice last comment. And I think I can summarize that all our empathy is with our long COVID patients, and that people like Professor Altmann are doing their best to come up with solutions, finding the origins, finding the causes, the pathogenesis, and best treatments. This was our second Global Healthcast on COVID special covering long COVID with Professor Danny Altmann. Today is August 18th, 2023. Please like, share, and leave your comments below in the link. Thanks for joining us today. I am Joe Schmitt.
I am Catherine Weil-Olivier.
I'm Danny Altmann.
And thanks to all. It was a very fascinating meeting. Thank you so much.